This conference will now be recorded.
Okay. Today's class is epilepsy and seizure disorders in children. So outline of this today's topic is definition on terms, definition of these terms, seizures and epilepsy, status epilepticus and its management, and febrile seizures. So what is tonic? Tonic means increase in tone, muscle tone or rigidity. Atonic means lack of movement or flaccidity. Clonic means rhythmic muscle contraction and relaxation. Myoclonic means brief jerks, twitches of a muscle or a group of muscles, not completely limb, but a group of muscles or individual muscle groups also. Means flexors or sometimes extensors. Okay. Aura means something before the onset of seizure. Perceptual disturbance, that is before the onset of seizure. Automatisms means coordinated involuntary movements such as chewing movements, lip smacking, tongue thrusting, pedaling movements. All these are automatisms. Postictal state means events immediately after the seizure. Most probably sleep, headache, confusion, hemiparesis. Postictal means immediately following the seizure. What happens? Loss of consciousness, confused, or having paralysis of one side of the body, headache, sleep, all this. Provoked seizure means caused by an underlying disease or event. Okay. So, example, head injuries can provoke seizure due to intracranial bleed or some fracture skull, which is impinging on the brain tissue, and stroke due to cerebral edema and damage, ischemia, CNS infection or a tumor, intracranial surgery, exposure to drugs or toxins, drug or alcohol withdrawal, and fever. All this can provoke seizure. So, seizure and epilepsy. Seizure or convulsion is paroxysmal. Paroxysmal means sudden, transient change in motor activity and or behavior that results from abnormal electrical activity in brain. Okay. So, most seizures in children are provoked by somatic disorders originating outside the brain. So they are not from the completely from the brain tissue. There some trigger is there, that is high fever, infection, head trauma, hypoxia, toxins, or cardiac arrhythmias. Okay, anything can trigger a seizure. Epilepsy means tendency to have recurrent seizures, that too unprovoked seizures. So defined as recurrent unprovoked seizure. Epilepsy is a tendency to have recurrent unprovoked seizures is called as epilepsy. So epidemiology, the seizures, how common in pediatric age group is up to 10% of children may have seizures in their lifetime. Less than 1/3 of these seizures are caused by epilepsy. Means epilepsy is very rare, but still some children can have epilepsy. The incidence of childhood epilepsy is 1 to 2%. So very less incidence. So if example 10 children had seizure in the early childhood, only 1% maybe of them may turn up into epilepsy. Etiology, majority of the times we don't know what is the underlying etiology. So idiopathic in 60% of cases, more than 60%. Genetics also not a single gene defect that causes seizures leads to epilepsy. So it is an interaction of multiple genes and environmental factors also responsible. So genes encoding for GABA receptors. GABA receptor is a major component of inhibitory circuit and ion channels. So gene encoding these GABA receptors and ion channels can lead to epilepsy in some cases. So what are the acquired causes of this seizures or epilepsy? Is injury, head trauma, brain tumor, space occupying lesion, stroke. It is the leading cause in adults, but not in children. But in young children, it can be a cause. Previous infection, birth defects like abnormal brain structure, autoimmune disorders. So the commonest cause of convulsions in neonates are hypoxic ischemic encephalopathy, CNS infection, hypoglycemia, hypocalcemia, and treatment of these convulsions. Already we know convulsions, the commonest drug of choice that we use in neonates for seizures is phenobarbital. So what is the pathophysiology? Always the brain of a child is more of excitatory than inhibitory. So a balance between the excitation and inhibition is essential for a normal brain function. So the balance is already somewhat towards excitation in a child, but due to some external other somatic causes, what we discussed previously, infection or fever or tumor, all these can trigger this balance and shift this balance towards excitatory, so that seizures can occur more commonly in children than adults. So a seizure results when a sudden imbalance occurs between excitatory and inhibitory forces within the network of cortical neurons in favor of a sudden onset net excitation. So synchronous firing of many neurons at once occurs. So symptoms and type of seizures will depend on affected area of the cortical network. So if frontal lobe is affected, that what the functions of the frontal lobe, consciousness losing and intellectual things and speech, all this may be affected. And if parietal lobe is affected, where the consciousness as well as receptive speech and numbness, all this can occur. And temporal area, hearing can maybe lost or some aura can occur, all these can occur. Okay, so why are seizures more common in children? Because their excitatory postsynaptic potentials develop more quickly than inhibitory. So the brain, during the brain development, these excitatory postsynaptic potentials are easily developed and fired than the inhibitory potential, inhibitory postsynaptic potentials. Therefore, the brains are very much excited than inhibited in children. So if we classify epileptic seizures, they are generally classified as focal or partial or generalized seizures. So focal seizures or generalized seizures. Generalized seizures originate within and propagate throughout both hemispheres. So somewhere it will origin, but immediately it will be propagating throughout the both hemispheres, and there will be always associated with loss of consciousness. So may include tonic-clonic, Atonic seizures or myoclonic jerking. Okay, widespread cellular and biochemical or structural abnormalities can occur. So primary generalized seizure and secondary generalized seizure. Primary generalized seizure means seizure starts from both the hemispheres at the same time. Means the trigger will start in both the hemispheres at the same time on both sides of hemispheres. And secondary generalized means seizure may start in one hemisphere like a partial seizure and may get generalized, then moves on to other hemisphere. It ends up in on both sides. So grand mal epilepsy, tonic-clonic seizures. So typically the seizure begins abruptly, suddenly, and consciousness and control of posture are also lost. So child may fall down and get hurt also. So followed by tonic stiffening and upward deviation of the eyes. Okay, pooling of secretions and pupillary dilation, diaphoresis means excessive sweating, and hypertension are also common. Clonic jerks following tonic phase. So initially there will be tonic, means we already seen that rigidity, okay, or increase in muscle tone, followed by clonic jerks. Okay, so in the post-ictal phase means following seizure, the child might be hypotonic. The tone may be less after seizure attack. So irritability and headache are common in the post-ictal phase as the child awakens. okay, due to some edema in the brain tissue. Petit mal, bar in bracket absent seizures. So petit mal seizures, the clinical hallmark is brief, that is less than 15 seconds, brief loss of environmental awareness, which may be accompanied by some automatisms. See, someone child may be looking at the blackboard in the class, maybe looking consistently with the fluttering of eyes. He will not see any other surroundings. He will be seeing at the blackboard and fluttering the eyes for transient period, like less than like 10 seconds or 5 seconds, and very difficult to recognize also, and it is very common also. So loss of environmental awareness, but loss of consciousness will not be there in this absence seizures, okay, which may be accompanied by automatisms. Example, eye fluttering, fumbling with the fingers, lip smacking, can be caused by a complex partial seizure. They are usually benign between the age of 4 to, means mainly in school going age. Initially, after the toddler, they will start. They usually they are benign, and between the begin at the age of 4 to 6 years. Neurological examination and brain imaging will be completely normal. So the characteristic EEG pattern consists of generalized 3H spike and wave pattern. So 3H spike and wave pattern is seen in this absence seizures and can be provoked by hyperventilation or strobe light stimulation. So stimulation tests work on EEG. We can see only mainly on EEG, and it is very difficult to pick up clinically unless some teacher is trained in it. So what is atypical absence, myoclonic and atonic seizures? So atypical absence seizures are episodes of impaired consciousness with automatisms, autonomic phenomenon and motor manifestation, slower EEG discharges. So episodes of impaired consciousness with automatism, but may not be complete absence, the complete loss of consciousness, but impaired consciousness will be there. Myoclonic epilepsy usually is associated with multiple seizure types, not a single seizure type. Myoclonic epilepsy usually is a bad prognosis, and atonic seizures typically brief, lasting for 1 to 2 seconds only. But it is quite disabling because once tone is lost in the body, we may fall down. Because if there is no tone in our muscles, we will fall down. We cannot stand against gravity. So one sudden loss of postural tone will lead to fall and injuries. Okay, so atonic seizures may cause head injury or injury to other body parts. And partial seizure, focal or partial seizures, it originates within the one part of the hemisphere or some small one part of the hemisphere or small part of the brain, and within that hemisphere, and then propagate throughout one hemisphere. Then later it can be generalized by progressing to other hemisphere also. So usually partial seizure means it will originate within and propagate throughout one hemisphere only usually. So may have motor, that is tonic, clonic, myoclonic, sensory, numbness, and some tingling sensations can be there. Cognitive, so impaired consciousness, and emotional, they may cry and irritable, and psychic or autonomic abnormal, like increase in heart rate. All these can be there in partial seizure, usually associated with local structural abnormalities, means like some focus in the brain, like neurocysticercosis. Example, I think you already know about neurocysticercosis. It is a focal etiology, and there will be focal edema in around that lesion. It will trigger seizure. And brain tumor also is a common example of partial seizures. Okay. And partial seizures are common in temporal lobe epilepsy. Focal may progress to generalized with the loss of consciousness. So focal means we already discussed, it will originate in one part of the hemisphere, and it can generalize and spread to other part of the brain also, hemisphere also. So symptoms will vary according to whether the seizure occurs, where the seizure occurs, sorry. In the frontal lobe, if it occurs, there can be fumbling of speech, or a loss of speech, or twisting movements, turning, pedaling movements can be there. If it occurs in temporal lobe, a feeling of deja vu, means something previously happened to me, similar things are happening again. That is a feeling of deja vu. In the parietal lobe, a numbness or tingling sensation can be there, and in occipital lobe, visual disturbances and hallucinations might be there. So it depends on which lobe of the brain the seizure is started. So based on that the symptoms might be there. So frontal lobe, temporal, parietal and occipital lobes. So roughly you remember, frontal means speech, temporal means deja vu phenomenon, parietal lobe means tingling and numbing, occipital means visual disturbances. So in partial seizures also two varieties are there. One is simple partial, another one is complex partial. A partial seizures without dyscognitive features means the loss of consciousness completely, and other whatever we have discussed, all these things may not be there in simple partial. Usually the event is remembered in detail by the child or the patient. So simple partial is not that having any other dyscognitive features. Complex partial seizures will have dyscognitive features. There will be loss of consciousness or change in consciousness. Patient may not be aware of the complete episode and responsiveness. Patients may have staring look and automatism. Typically the frontal and temporal lobe is the onset for this complex partial seizures. So frontal and temporal lobes are the common for complex partial seizures. So when focal seizures spread to involve the whole brain, we already discussed, that is called as secondary generalized seizure, secondary generalization. So initially with the origin is in one hemisphere, that is partial, and lateral it is spreading to other part of the hemisphere and to the other hemisphere also. So that complete it will be generalized, it becomes generalized seizure. The initially it starts with focal and lateral generalized seizure, it is called as secondary generalized. Such spread is clinically described as progression from face to arm, then to leg, like a Jacksonian march. So that then it is called due to secondary generalization. Usually whenever the child is having seizures, we should always ask these questions. Was any warning sign noted before spell? Means aura. Some may feel visual hallucinations, some may feel deja vu phenomenon, some may feel smell also might change, anosmia or hyposmia can occur, or different some awkward smell also can occur. So and some twitching movements, all this the child can Am I audible, CR?
Yes, sir.
Yeah. Epilepsy syndromes. Coming to epilepsy syndromes, these are few epilepsy syndromes. Benign childhood epilepsy with centrotemporal spikes. You just know the terms, that is more than enough. Benign childhood epilepsy with centrotemporal spikes, also called as benign Rolandic epilepsy. Childhood absence epilepsy. Juvenile myoclonic epilepsy of Zanz. Infantile spasms, West syndrome. Lennox-Gastaut syndrome. Benign neonatal convulsions. Acquired epileptic aphasia, Landau-Kleffner syndrome. So these are the common epilepsy syndromes in children, but per se epilepsy syndromes in children is very rare. So benign childhood epilepsy with centrotemporal spikes, also known as benign Rolandic epilepsy, childhood absence epilepsy, juvenile myoclonic epilepsy of Zanz, infantile spasms, also known as West syndrome, Lennox-Gastaut syndrome, benign neonatal convulsions, acquired epileptic aphasia, also called as Landau-Kleffner syndrome. So Lennox-Gastaut syndrome, or also called as childhood epileptic encephalopathy, is a severe form of epilepsy syndrome characterized by frequent multiple seizure types and resistant to medications also. So they may be difficult to control seizures also. Abnormal EEG findings and moderate to severe intellectual disability. So whenever the epilepsy syndrome is, when we call it as very severe, means difficult to control convulsion and associated with severe EEG abnormalities and moderate to severe mental retardation. That we nowadays we are calling it as intellectual disability. So most children present before the age of 5 years. This Lennox-Gastaut or epileptic syndromes usually before the 5 years only the age of onset will be. So many children have underlying brain injury or malformations. And coming to Dravet syndrome, it is a rare lifelong genetic epileptic encephalopathy, non-hereditary gene mutations in ion channels. It is not hereditary and there will be gene mutation in sodium ion channels. So present in infancy, that is less than 1 year of age, with polymorphic seizures, different variety of seizures. Some degree of development disability will always be there. So developmental delay will be there. First seizure usually associated with fever first. So after that there may not be any fever. Then occur without fever but can be triggered by slight changes in body temperature, infection, flashing light. So Dravet syndrome is also one of the, it is though rare, if it is present, it is one of the very bad prognosis, Dravet syndrome, so, due to with the developmental delay. So sudden unexplained death in epilepsy is also common in some sort of seizures whenever the seizure is prolonged also. So high risk people with difficult to treat epilepsy who have tonic-clonic seizures, who are on multiple seizure medications and who have developmental delays. Okay. Other causes of mortality are associated with Dravet syndrome include status epilepticus and accidental death from injury or drowning. Okay. The usually seizures, the differential diagnosis, different causes of seizures are fever, meningitis, encephalitis, brain abscess, sepsis, tetanus, birth asphyxia, head trauma, including child abuse. Metabolic causes mainly sodium, low sodium, hyponatremia, hyperbilirubinemia, DKA, diabetic ketoacidosis, hypoxia, toxins, ingestions, ingestion of some toxins, drug medications or withdrawal from drugs. Alcohol is not there in children, it is in adults. Stroke, transient ischemic attack, syncope, arrhythmia, brain tumor, mass, brain mass, or psychogenic causes, night terror, sleep awakening, and sleepwalking, migraine. Okay. Oh, so how will you do physical examination during seizure or after seizure? Vital signs should be always monitored. So heart rate, respiratory rate, breathing pattern, airway maintenance is very important. Be blood pressure checking and temperature. Okay, and maintain mental state of alertness. Often lethargic or sleeping immediately after seizure. Post-ictal phase, child may be lethargic, hypotonic, and sleeping. History of psychiatric disease also should be evaluated. Eye, retinal hemorrhages might be there, trauma, papilledema, increased intracranial pressure. Mouth, there may be tongue lacerations, okay, because of tongue biting between the teeth during seizure. So neck stiffness might be there, meningitis and carotid vessels should be palpated and look for bruit in case of stroke. Cardiovascular, we should always look for rhythm. So ECG might be important in some cases. And murmur due to stroke or embolic, and from that, and it will cause stroke in the brain. And neurological causes like cranial nerve deficits, hemiparesis, paralysis, post-ictal phase, there may be hemiparesis, and deep tendon reflexes may be depressed, gait and coordination may be affected. Skin, some, because seizures skin means this tuberous sclerosis or some conditions might be there, neurofibromatosis, tuberous sclerosis, all these conditions may have skin manifestations also, neurocutaneous syndromes. So we should look also for skin, any skin abnormalities. So immediately investigations, prolactin levels is an experimental thing, but no one is doing now. So usually post seizure there is a 3 to 4 fold elevation in prolactin levels, but it is not consistently observed. So that is not being used now. And lumbar puncture is very important in less than 1 year old or up to 18 months of age. We should confirmly do an LP if there is associated with obtundation and or the patient with meningitis, suspected meningitis. We should always get an LP done, lumbar puncture done. Serum levels of anticonvulsants. Previously, the child is already having seizure disorder and on anticonvulsant therapy. We should always look for baseline anticonvulsant level. Maybe child would have not taken medication in the past 2 days or forgot to take medication due to travel or something. We should always check the baseline levels if available. Potential toxicity, maybe they would have taken 2 to 3 times of the normal dose. Lack of efficacy, say maybe that would, whatever dose we are treating the child may not be effective or efficient. So treatment of non-compliance is important, means they are not taking properly, we should advise them. So other lab important things are always blood sugar in case of mucopolysaccharidosis, complete blood count for infections. Urine analysis also is very important in case of some metabolic disorders. Glucose for hypoglycemia, renal function tests, electrolyte disturbances, blood urea, nitrogen and creatinine levels. HIV usually we have to screen because HIV also will lead to encephalitis that can cause seizures. So consider drug withdrawal, not alcohol, drug withdrawal, and consider AST, ALT, and bilirubin, hepatic function also, because valproate if the child is taking, we should always look for liver dysfunction. Consider ECG in case of suspected arrhythmias. Okay, imaging studies. Important imaging study that we have to do is EEG, electroencephalogram. Electroencephalogram should be performed if possible within 1 to 2 days on all patients with seizure of unknown etiology or unprovoked seizure. So in unprovoked seizure, 100% we should get an EEG done. Maybe able to diagnose a seizure disorder in it, may be able to predict future seizure or epilepsy tendency. We can predict up to 60% of pediatric cases of new onset seizure will have epileptiform abnormalities. So we should always get an EEG done wherever possible. Often done with hyperventilation, light stimulation to induce seizure activity. Okay, so induced seizures are very important. Stimulation by stimulation. May also perform sleep deprived EEG if due to sleep deprivation is also a form of provocation. So we will ask child to sleep less and we will awake them and we will get an EEG done. If it is normal, if the initial EEG is normal, then only we will perform this sleep deprived EEG after 3 days for high yield of abnormalities. Then we can look for MRI and CT brain. CT brain for intracranial hemorrhages or any masses or edema, we can get in CT brain and calcifications. In MRI brain, we will see the cortical structural abnormalities like congenital, some abnormal encephaly or parencephalic cyst or something in the MRI structural abnormalities. Okay. So if you see here, partial seizure, only one half. This is the EEG 1, 2, 3, 4. These are the 8 are there. No, this 4 in the upper one is indicating one half of the brain, and this is the other half of the brain. So in the first half or one half of the brain, there is epileptic seizure activity. If you see here, generalized seizure, it is in the whole part of the brain, complete brain. It is at the same time. This seizure starting as partial seizure may become secondary generalized also, or initiation itself can be complete primary generalized also. So what is the management? Medications usually target sodium ion channels and GABA receptors. Okay, these are the excitatory channels, these are the inhibitory channels. Usually these medications target these two channels. Keto diet, ketogenic diet. Nowadays it has become famous for weight loss also, no? But we use ketogenic diet for to reduce or prevent seizures in many children who are resistant refractory seizures. We use this technique for refractory seizures. We don't know how it gets controlled also. Reason is unclear. Deep brain stimulation, nerve stimulation therapies, deep brain vagus nerve stimulation. The stimulation device acts as pacemaker for the brain. Okay, so it will reduce the seizure tendency. Surgery to remove that part of the brain that causes seizure. Okay, lobectomy. Goal of treatment is to achieve a seizure-free status without adverse effect. So, what is the goal of treating a child is seizure-free status without adverse effects. So, always monotherapy is important. So, single drug we should maintain the seizure-free with single drug rather than 2-3 drugs. Okay, because if we use 2-3 drugs, drug interaction might be there and adverse effects also will be high. So, start an anticonvulsant if the child had more than one unprovoked seizure. If the child is having one, for not for just for one unprovoked seizure, we should not start. If more than one unprovoked seizure, get an EEG done and definitely start the child on anticonvulsant. And on EEG, if the child is having abnormal sleep deprived EEG, definitely we should start on anticonvulsant therapy. Commonly used medications are primary generalized tonic-clonic seizures, partial seizures absence, and atypical absence of myoclonic atonic seizures. So, first line for primary generalized tonic-clonic are valproic acid, lamotrigine, topiramate. These are the first line. Alternatives are zonisamide, phenytoin, oxcarbazepine, carbamazepine, oxcarbazepine, phenobarbital, primidone, felbamate. In partial seizures, phenytoin, carbamazepine, lamotrigine, oxcarbazepine, and valproic acid. And second line, levetiracetam, topiramate, tiagabine, zonisamide, gabapentin, phenobarbital, primidone, felbamate. Absence seizures, valproic acid, ethosuximide. Second line, lamotrigine, clonazepam can be tried. And atypical absence or myoclonic or atonic, valproate, lamotrigine, and topiramate. And alternatives are clonazepam and felbamate. So, what are the side effects of epileptic? Commonly used phenytoin. So, phenytoin higher levels may lead to cardiac toxicity, arrhythmias, and hypotension, poor coordination, nystagmus, okay, toxic epidermal necrolysis, peripheral neuropathy, status epilepticus, phenobarbital, sedation, and sometimes coma also if you give in high doses. Valproic acid, thrombocytopenia, encephalopathy, hypothermia, and hepatotoxicity is also important side effect of valproic acid. Status epilepticus. You already know it is a neurological emergency and is defined as ongoing seizure activity or repetitive seizures without return of consciousness for greater than 30 minutes. This is the previous definition. Now the definition has changed up to 5 minutes. If the seizure is uncontrolled or the loss of consciousness for more than 5 minutes, we will take it as status epilepticus. So 14% risk of new neurological deficits if you don't treat status epilepticus promptly. There is 14% risk with every status epilepticus new onset of neurological deficit. Mortality rate of status epilepticus is 4 to 5%. Is related to the underlying etiology. Etiology for status epilepticus: new onset epilepsy of any type, drug intoxication or drug withdrawal. There is a missed anticonvulsant doses among children with pre-existing epilepsy. That's what I told. Acute head trauma, infection, ischemic stroke, intracranial hemorrhage, metabolic disorders. Example: hypoglycemia and electrolyte imbalance, hypoxia. So management, always important thing is first to stabilize the patient. Airway, breathing, circulation. So adequate airway, position the airway such that it does not get collapsed. Breathing, look for breathing. If your child is not breathing, we may have to give rescue breaths. And circulation. So vital signs should be obtained and oxygen administration if needed. If saturation is coming down, always we should start the child on oxygen. If child is not breathing, positive pressure ventilation also we should be giving with bag and mask, ambu bag. IV access to get blood samples as well as to give first dose of drug also. So in patients with no history of previous seizures, laboratory evaluation should be undertaken. Basic lab investigation like glucose, calcium, metabolic panel, toxicology screen. What if child would have intoxicated something? So paracetamol, camphor, all this can be taken. Anticonvulsant levels. Previously, already a child with epilepsy on anticonvulsant now came with breakthrough seizure. Anticonvulsant levels also we have to send. CBC for infection. So pharmacological management include, first of all, we should give some benzodiazepine like lorazepam. Nowadays, diazepam is not being used, and lorazepam is more commonly used because of long half-life and less side effect, less risk of respiratory depression. Midazolam can be used like Midasip nasal spray is available. to immediately control that status epilepticus. If seizure does not resolve after 2 doses of benzodiazepine, a second line agent, these 2 doses also should be within a span of 3 to 5 minutes we should give. If it is still not getting controlled, second line drug IV phenytoin loading should be given over usually 15 to 20 minutes, or phosphonatoin is also effective to reduce cardiac abnormalities or arrhythmias. If the seizure persists, a loading dose of phenobarbital over 15 minutes should be given. Alternately, continuous infusions such as midazolam or phenobarbital can be employed as third line. Okay, and but with appropriate airway protection, intubation should be done. BP support, BP should be recorded and appropriately managed, and strong consideration of continuous video EEG monitoring to evaluate for ongoing subclinical seizures. So this is very important. If required, general anesthesia also should be given. General anesthesia means inhalational anesthetic. When status epilepticus stops, maintenance therapy is initiated with the appropriate anticonvulsant. Febrile seizures, this is common in children, and it occurs between 6 months and 6 years of age with temperature of more than 38 degrees or 100.4 degree Fahrenheit. Not due to other causes like CNS infection will not be there, metabolic abnormalities will not be there. This is due to just temperature. Seizure in the setting of fever may be caused by CNS infection like meningitis, encephalitis, brain abscess, unrecognized epilepsy triggered by fever or febrile seizures. So first episode of febrile seizure may turn into an epilepsy also, we don't know. The most common cause of seizure among children between 6 months and 6 years of age is febrile seizures, occurring in about 4% of all children. Simple febrile seizure and complex febrile seizures, 2 types are there. Simple febrile seizures are generalized at onset, but it lasts less than 15 minutes and occurs only once in 24-hour period in a neurologically and developmentally normal child. It will not recur. But in case of complex febrile seizures or atypical febrile seizures, these are focal seizures, not generalized. Usually these seizures last for longer than 15 minutes. It will recur within 24 hours period, or if the child is having pre-existing neurological challenges, this is bad. The prognosis of children with simple febrile convulsion is very excellent. Intellectual achievements are normal, means no developmental delay in simple febrile seizures. Febrile seizures recurring in 30 to 50% of children, means if in this episode one seizure occurred, maybe after a few months one more time child may have fever, child may have second time febrile seizures also. So 30 to 50% of them may have recurrent. The risk of subsequent epilepsy is not substantially greater than that of general population. So again, the conversion of febrile seizures into epilepsy is not that common. So it is the risk is similar to general population. Those who don't have febrile seizures also have same risk. Factors that increase the risk for development of epilepsy are, so if a child with febrile seizure came and you have examined the child, if there is the abnormal neurological examination or developmental delay, that is one risk factor. Family history, one of the family member is an epileptic and on medication, that is one of the risk factor. And the child is having complex febrile seizure or atypical febrile seizures. These 3 are important risk factors. Patient with 2 risk factors have up to 10% chance of developing a febrile seizure. So these are important risk factors. Increase in mortality, if seizures occur before 1 year and triggered by temperature less than 39, means it is high chances there is mortality risk is also there. So how do you manage febrile seizures? Specifically, there is no treatment for febrile seizures, and as they are brief and benign. Rectal diazepam they used to use, but nowadays nothing is being used. Only we will give midacip spray if it is converting into status epilepticus. Undress the child, give paracetamol after seizure because to reduce the temperature. Because of the potential for side effect, daily administration of anticonvulsants is not recommended. We should not give anticonvulsant for febrile seizures. It is self-limiting. Administration of antipyretics during febrile illness does not prevent febrile seizures. Okay, so some fever has occurred, you have given paracetamol. You don't think that febrile seizures will not occur. Even though the temperature is coming down also, child can have a febrile seizure. So Thank you for your attention. November month is epilepsy awareness month. Okay. Did you give your attendance CR?
Yes, sir.
Okay. What's the time now? 12:34. Okay. So next class for you, I think nutritional anemias on 26th. Okay.
Okay, sir.
Okay. You have given attendance, all of you.
Yes, sir.
Okay. Then you can leave.